Welcome back to part 2. Let's keep going. Now we're going to talk about some defects that obstruct systemic blood flow. And the names of those are listed for you on your slides. COA stands for a coarctation of the aorta. Basically what you get is narrowing of the descending aorta, often near the ductus arteriosus or the L subclavian artery. This obstructs systemic circulation. This occurs in 5 to 8% of children with congenital heart disease. You've got a great graphic of it. See how up there where it says coarctation on your graphic, how it points, how that part of the aorta is so narrowed? Beautiful. So babies who have a coarc, they can be asymptomatic unless it's majorly constricted, in which cyanosis of the lower extremities may occur. Renal failure and NEC, that's that necrotizing enterocolitis, can occur with this. Because again, renal failure and NEC, that means you're not going to get good and adequate blood perfusion to the lower extremities. Kidneys like their blood. They get pretty snarky if they don't get a lot of blood flow. And the bowel really likes blood flow and perfusion too. It gets pretty snarky if you reduce blood flow to the bowel, so it just dies. Older children who have a coarc may complain about weakness or pain in the legs after exercise. For diagnosis, 4 extremely blood pressures can be helpful. You're looking for blood pressure that's going to be higher in the arms than is in the legs, weak or absent femoral or pedal pulses, and then you combine that with brachial and radial pulses that are bounding. So as far as the repair goes, they could either dilate with a balloon, or they will go through and they will cut out the part of the aorta that is kinked off or narrowed, and then reanastomose the other ends together. You may end up with some chronic hypertension afterwards, and it's important to note that the coarc may reoccur. I will tell you guys a personal story. My brother had a coarc, probably had it since birth. It was asymptomatic. He never knew about it until he had heart surgery when he was around 5 years old. He's my oldest sibling, so I of course was not around, so I don't remember any of this. I just have my mom's record to go by. But she said that she noticed that when he was little, he would go outside and play, and he couldn't play and keep up with the other kids. And he'd go outside for a very short amount of time and come back in and be red-faced and sweating and exhausted and tired. And she kept taking him to the pediatrician, and she said, something's wrong. Something is wrong with him. And the pediatrician at first, my mom, she was just being crazy, and he just needed more exercise, and he was a thin boy anyway. And my mom said, I don't think so. So she was a smart person, and she said, I think he's got a cardiac defect. And so she took him to a different cardiologist who did some testing, and yeah, indeed, he had a coarctation of the aorta. So when he was 5 years old, he had open heart surgery, and they cut out the spot because it was pretty severely kinked off, I guess. They cut out the bad kink and then reanastomosed the other sides. He spent some time in the hospital and has had a full life ever since. But he does have hypertension now. But he is, like mid-40s, so it's kind of to be expected. So aortic stenosis means that you have a narrowed aortic valve, which is going to obstruct blood flow to the systemic circulation. This makes the left ventricle get bigger over time, and that can progress into left-sided heart failure. And that is no bueno. So the clinical manifestations associated with aortic stenosis would be chest pain, syncope, and unfortunately, sudden death can occur with this defect as well. Stenosis may reoccur following intervention and may worsen as the valve calcifies. Valve replacement may be needed, but it would also require lifelong anticoagulant therapy. Prognosis, again, if they choose to replace the valve as a child, the child may need repeated valve replacements or dilations as the kid grows up. And again, I just want to say sudden death can occur with this. PS stands for pulmonary stenosis. With this, you can get narrowing of the valve area, or the great artery above the valve. Any of those three little areas all classifies as pulmonic stenosis. The stenosis obstructs the blood flow to the pulmonary artery, which increases the preload and the child ends up with right ventricular hypertrophy. This is the second most common heart defect, resulting in 8% of all cardiac kids. And 30 to 50% of cases, it occurs in conjunction with other defects too. All right, so now let's talk about some defects that decrease pulmonary blood flow. These are the defects that obstruct blood flow from the right side of the heart to the lungs. This results in little or sometimes even none of the blood reaching the lungs for oxygenation. If there are atrial or septal defects, like the ones we just talked about, blood is going to be shunted from the left to the right. But if the flow to the lungs is obstructed, then the right side of the heart has the higher pressure, and blood will be shunted from the right over to the left. Does that make sense? Classic sign for this is cyanosis that does not respond to oxygen therapy. So if you see a kid and they are blue and you put them on oxygen and they don't pink up, boom, that is a classic sign. They have a major cardiac defect such as this that is decreasing blood flow to the lungs. Okay, so trying to talk about clinical manifestations. We kind of have to do initial ones and then later ones. Initially, cyanosis occurs when the PDA closes because it causes hypoxemia. Skin may be very ruddy or mottled before the cyanosis sets in. Children may have dyspnea and they're going to have a loud murmur. They're going to have cyanosis that does not respond to oxygen. Later, as this becomes a chronic issue, they're going to have polycythemia. Why? Because of the cyanosis. The kidneys are going to release erythropoietin, which tells the bone marrow to ramp up production of red blood cells to haul around more oxygen. Because clearly, if we're hypoxic and we're not getting oxygen, it must be because we don't have enough trucks on the highway. In fact, you actually do. So then when you ramp up production, when the bone marrow ramps up production, makes more red blood cells, we end up with too much trucks on the highway. We kind of end up with polycythemia and we kind of end up with some traffic jams. Chronic polycythemia causes sluggish flow through the capillaries and small vessels, increasing the risk for thrombus. Boom, I just told you that. It's like a traffic jam. Too many red blood cells on the highway at one time during rush hour with road construction, trying to go through narrow little one-lane bridges, and everything comes to a stop, and you end up with an embolism. You can also get a brain abscess. This is more common in children with these kinds of defects because the lung capillaries that should normally filter out bacteria are bypassed since there's decreased lung flow. So that's a bummer. Fatigue and dyspnea, yeah, not too surprising here. Clubbing of fingers and toes. This is due to the chronic hypoxia. Poor feeds, poor weight gain. Again, cardiac kids have an increased metabolic rate and they have a need for increased oxygen because of that. And I've already told you guys before, cardiac kids, they can't eat like a regular baby can. They don't eat as well. They need high calorie foods in smaller volumes. These aren't the kids that need to be on, you don't need to put them on a diet. They're the kids that need cheesecake. They need food. They need calories in a small amount of volume. And then TET spells. We'll talk about that a little bit more in the next slide or two, I think. TET spells occur when there is severe obstruction to pulmonary blood flow and hypercyanotic episodes occur. I think I have a picture on the next few slides. All right, so this obviously is not a real picture, but it's a picture graphic representation. Hopefully it will help you guys see the things you need to see. This toddler is having what's called a TET spell. These can occur when the child wakes up or when they experience an abrupt drop in their systemic vascular resistance and pulmonary blood flow. When this is combined with a sudden increase in cardiac output and venous return, such as crying, feeding, bathing, pooping, exercise, a quote, TET spell occurs. The PO2 is lowered, the CO2 increases. The brain overreacts and increases the respiratory effort because it says, oh my gosh, our O2 is low and our CO2 is high. We need to breathe. We need more oxygen. But this only makes the problem worse because if this doesn't get fixed, this can be life-threatening for children. The immediate treatment for a child who's having a TET spell is to get them into the knee-chest position to relieve the dyspnea. These positions reduce cardiac output by decreasing venous return from lower extremities, which increases the overall systemic vascular resistance. Whew, that's a lot to think about, right? TET spells usually occur between 2 months and 2 years of age. Signs include an increased rate and depth of respirations, an increased cyanosis. Look at where the baby is cyanotic in this picture. Toes, fingers, mouth. Circumoral cyanosis, look for those things. Pallor, they're going to get real white all over. Poor tissue perfusion, increased heart rate, diaphoresis, irritability, crying, seizures, and eventually loss of consciousness. Eventually, children can die from this if you don't do something to relieve it. Older children may experience exercise-induced dizziness and syncope. So these, quote, TET spells occur because the child has what's called Tetralogy of Fallot. This results from underdevelopment of the outflow portion of the right ventricle. This is one of the most common defects causing cyanosis and makes up 6% of all cases of congenital heart disease. Elevated pressures on the right side of the heart cause a right-to-left shunt. There are 4 main defects that must occur, and those are listed for you on your sides. But you have to have pulmonary stenosis, which basically is going to obstruct the right ventricular outflow. You have right ventricular hypertrophy. Because of the pulmonary stenosis, the severity of this depends on the severity of the pulmonary stenosis. So those two kind of depend on each other. You have an overriding aorta. The aorta is placed over and above the VSD. And then you have to have a VSD as well. And then you end up with cyanosis because unoxygenated blood is what ultimately is being pumped out. Tetralogy of Fallot this condition is going to require many surgeries as the child grows. This is not a one and done kind of surgery. One surgery is not going to fix it all. Children who have Tetralogy of Fallot end up with multiple surgeries to repair it and fix it. It can be sometimes a multi-stage thing. And then as the child grows, they're going to need additional heart surgery as well. Usually the first surgery is done between 4 to 6 months of age. However, some babies may have some palliative surgery done at 4 months or even prior to 4 months if there are TET spells to allow the babies to have a little bit more time to grow before they start doing the big repairs. And not every single defect may be able to be fixed and cured by surgery either. However, the surgery will improve the quality of life and longevity. There are future life-threatening arrhythmias that are a possibility as well. All right, tricuspid and pulmonary atresia. In this condition, the tricuspid valve is missing. So there's no communication between the right atrium and the right ventricle. The right ventricle is hypoplastic or very poorly developed and kind of non-functional. Blood from the right atrium flows over to the left atrium via the PFO. The PDA is the only way to get blood over to the lungs. In pulmonary atresia, there is no communication from the right ventricle to the left pulmonary artery either at the site where the pulmonary artery should be or in the pulmonary artery itself. Again, treatment is going to be prostaglandin to maintain the PDA. This is one case where we do not want to close that PDA. We need the PDA to stay open. And remember, after babies are born, the PDA wants to close. We have several mechanisms in place, biological mechanisms that tell the PDA to close, but we do not want this. So these babies need to be diagnosed as soon as possible after they're born, and then they need to they'll be NICU admissions for sure, and then they will put in IV lines. They'll put in umbilical lines. They'll do all kinds of things so they can monitor blood gases, but they will start a IV infusion of prostaglandin to maintain that PDA and keep it open. The repair is going to be a surgical prognosis, right ventricular arrhythmias, 5-year survival rate and 10-year survival rate they both look pretty good.